Hi everyone and Assalamu alaikum. This is Dr. Chaman Khan and today we will be discussing some common benign diseases of breast. We take a start with a scenario. A 16 years old student presents with off and on pain in both of her breasts for 2 months. On examination, her both breasts are tender. However, no definite lump is palpable. What is the most probable diagnosis? What additional questions you will ask her? How you will treat this patient? Well, our diagnosis is mastalgia. Mastalgia is the most frequent reason for breast-related consultation in general practice. It accounts for approximately 50% of referrals to the specialized breast clinic. It's a general term for breast pain, and it is one of the most common symptoms, and it affects up to 70% of the women at some time in their lives. Mastalgia can be cyclical, non-cyclical, or this can be a non-memory pain. That is, this can be a pain in the chest wall, or this can be a pain in some other viscera. The cyclic mastalgia is related to the menstrual cycle in luteal phase, and it resolves with the onset of menstruation. It can stay there for more than 7 days. The premenopausal age group is most likely affected. It presents with moderate to severe bilateral diffuse pain. That can be unilateral as well. Patients present with premenstrual breast tenderness that occurs 2 to 3 days before onset of menstruation. The non-cyclic mastalgia usually presents with unilateral pain that occurs in specific quadrant of the breast. It is not related to menstrual cycle. Usually, the postmenopausal females in their 4th to 5th decade of life, they are most commonly affected. Non-cyclic mastalgia accounts for 31% of the breast pain. Its causes could be breast cysts, periductal mastitis, trauma, sclerosing adenosis, or Mondor's disease, and rarely it can be because of cancer. The principles of mastalgia treatment is you investigate the patient because you want to exclude the cancer. If by triple assessment there is no evidence of any cancer, you can provide reassurance to the patient. Cyclic mastalgia, it has overall response of 92% by treatment with evening primrose oil, danazole, or bromocriptine. While the non-cyclic mastalgia, it has the overall response rate of 64%. For musculoskeletal or chest wall pain, lignocaine steroid injection can also be administered. We take another scenario. A 20 years medical student presents with 2 small lumps in her left breast. The lumps are non-tender and quite mobile. Axillary lymph nodes are not palpable. What is the most probable diagnosis? Our diagnosis is fibroadenoma, which are benign abnormal growths of tissue in the breast, and they typically arise between 15 and 25 years of age. They are painless, firm, solitary, mobile, and slowly growing breast masses. They are common in adolescent and childbearing age of women. They are also called breast mouse because these lesions tend to slip under hand during examination. They are partially hormone dependent, so they regress after menopause. Fibroadenoma is spherical in shape. It has a smoother outer surface, in contrast to the malignant breast cancers, where margins are ill-defined. This picture can show you how fibrocystic changes in the breast and fibroadenomas, they differ from each other. Fibrocystic changes, they are most common benign condition of the breast that occur due to the fluid-filled sacs within the breast. These are cystic in consistency and may be painful. While fibroadenomas, they are benign, solid tumors containing glandular and fibrous tissue. They are painless, well circumscribed, round, and mobile. In fibrocystic changes, needle aspiration is helpful not only as diagnostic, but also as therapeutic modality. While the fibroadenomas, they are diagnosed by core biopsy, and then they are followed clinically or they are surgically excised. Evaluation of a breast lump or a fibroadenoma is done again by triple assessment, which includes history and clinical examination, imaging, and cytology or biopsy. This is how a fibroadenoma will appear on ultrasound. A well-defined lesion and a capsule can usually be identified. The echotexture is usually homogeneous, and it is hypoechoic as compared to the rest of the breast parenchyma. Typically, the transverse diameter is greater than the anteroposterior diameter. This is how a fibroadenoma will appear on mammogram as a whitish, opaque, well-circumscribed lesion. On the other picture, you can see the mammogram of a breast cancer lesion where this opacity is not very much well circumscribed and it has got ill-defined margins. Or you can see stellate-shaped lesions on mammogram. Long-standing fibroadenomas can get calcified in the body and take the characteristic appearance of a popcorn sign on mammogram. Here you can see in this mammogram a well-circumscribed mass, smooth lobulated borders, and dense popcorn-like calcification. This is how a fibroadenoma will appear on MRI as hyper-intense, well-circumscribed lobulated lesion with distinct margins. The treatment of fibroadenoma is enucleation. But for fibroadenomas who are larger than 5 centimeters, usually you need excision biopsy. What are giant fibroadenomas? Well, you call a fibroadenoma a giant fibroadenoma if the size is more than 5 centimeters in size. The clinical features, they will be the same as fibroadenomas, and there will not be any nodal enlargement. This picture shows how a giant fibroadenoma can result in breast asymmetry or distortion of the shape of the breast by bulging out from the rest of the breast. It becomes quite prominent because of its bigger size. So treatment of giant fibroadenoma is wide excision of giant fibroadenoma. That is, you try to remain outside the capsule and also excise a rim of the normal tissue around that. Let's move on to the next benign breast disease. We have a scenario. A 35 years married female presents with unilateral enlargement of her left breast for 6 months. On examination, left breast is enormously bigger than the right breast. Axillary lymph nodes are not enlarged. What is the most probable diagnosis? Well, the diagnosis here is Phyllodes tumor. Phyllodes tumor, it is an uncommon kind of tumor that is common in later decades of life. It is rapidly growing benign tumor, and the size can grow up to 40 centimeters. They are firm, well-circumscribed masses. Most of the times they are benign, but they can recur if not completely excised. You can see in this picture how a big phyllodes tumor can cause significant disfigurement of the breast. Phyllodes tumor, they are also called cystosarcoma phyllodes. They arise from the interlobular stoma. It is larger in size as compared to the fibroadenomas, and they're more cellular. By phyllodes, we mean leaf-like. The projections of stroma between the ducts create the leaf-like pattern for which these tumors are named phyllodes tumor. This is the mammogram showing how a phyllodes will appear on mammogram as an opaque, rounded, well circumscribed, bigger mass. On the other side, you can see a normal mammogram for comparison. Phyllodes tumors can be subclassified into 3 different categories. They can be benign, they can be borderline, or they can be having malignant potential. About 60% of the phyllodes tumors, they are benign. The 20% being the borderline cases who have some potential to become malignant. And the 20%, they are malignant who have the potential to metastasize. The perceived clinical relevance of grading phyllodes tumor is to predict clinical behavior. Benign tumors, if not excised properly, they can recur. The borderline tumors have the potential to recur locally, but have low risk for metastasis. But the malignant tumors, they have the highest risk of metastatic behavior, which may prove fatal. So it is accepted that all forms of phyllodes tumors, when they are subjected to complete local excision, the malignant phyllodes tumor, they account for 10 to 15% or 20% of the phyllodes tumor. They metastasize hematogenously. Recurrent malignant tumors, they seem to be more aggressive ones. The most common metastatic sites for malignant phyllodes are lungs, skeleton, heart, and liver. 30% of the patient with malignant phyllodes will die from this disease. Patient may present with symptoms of metastasis. So treatment of phyllodes is complete excision of the tumor. 2 centimeters of the normal tissue is taken all around as wide excision for small tumors, and 5 centimeters of the normal tissue or parenchyma is taken as wide excision for larger tumors. If tumor to breast ratio is greater, then you may need total mastectomy. In case of negative clinical axilla, axillary dissection is not recommended. So what is the treatment algorithm of phyllodes tumor? You go for the triple assessment. And you check the size of the tumor, you assess the tumor breast ratio, and you check the histopathology, whether this turns out to be fibroadenoma, in which you can go for observation if the size is less than 2 centimeter, or if larger, you can go for enucleation. If it is an indeterminate or joint fibroadenoma, you can go for excision biopsy. And if it turns out to be a Phyllodes tumor, you will go for a wide excision. And if the tumor breast ratio is more, you can also choose for mastectomy for that. What to do if the Phyllodes tumor recur? Well, you will do all the triple assessment workup. You will check for the metastasis. If the disease has not metastasized, you can choose for re-excision with wide margins and consider post-op radiotherapy. But if it is a metastatic disease, you will treat it as soft tissue sarcoma. That's all for today. Thank you very much. I hope you liked the video. See you next time.